Thank you, Dr. Mitchell. Each presenter in session 2 will have 6 minutes for their video presentations, followed by 6 minutes of Q&A. Let us congratulate Dr. Yibing Fang of the unit at Sichuan University West China Hospital for being the John Hawkins top scoring abstract winner. Dr. Fang's presentation is entitled, Amount of Aortopulmonary Collaterals Predicts In-Hospital Outcome in Tetralogy of Fallot with Pulmonary Stenosis. Dr. Fang.
Good morning, everyone. Thanks, committee, to give me a chance to present our study. The anatomic characteristics of aortopulmonary collaterals in patients with TOP PS remains unclear. The presence of APCs has been suspected to result in unfavorable postoperative hemodynamics. MDCT yield precise preoperative information regarding the detailed anatomy of the APCs with a marked decrease in the radiation exposure. To characteristics rise the anatomy of APCs in TOP PS and to investigate the influence of preoperative MDCT-driven APC density on the postoperative in-hospital course. This is our study design and population. MDCT is routinely performed for preoperative assessment because near 1/5 of patients at our institution were adults whose acoustic windows of echocardiography are usually poor. Preoperative CT was retrospectively analyzed for the anatomy of APC using the methods established in previous studies of bronchiectasis in normal population and patients with PA-VSD MAPCAS. The site of APC's ostium was reported as the orthotopic or ectopic. The origin of each APC was reported as directly from the aorta, common trunk, or intercostal trunk. A total of 337 APCs were detected in 135 patients. The number of right and left APCs were similar. The majority of APCs ostium sites were orthotopic. The most common sites of ectopic APCs ostium were at the aortic arch, followed by subclavian artery. Around 1/3 of APCs originate from aorta. The rest of them arose from the aorta as a common trunk or ICT. All of the 337 APCs caused along the ventral side of the esophagus. The proximal diameter of the majority of APCs were smaller than 2 mm. The distal diameter of APCs were obviously smaller than the proximal diameter. Only one APC showed proximal stenosis greater than 17%. Medial APCs number per person was 3, with majority less than 4. Indexed distal APC CAC was obviously smaller than indexed proximal APC CAC, and there was a significant positive correlation between the two groups. The mean APC's diameter was strongly correlated with age, preoperative arterial saturation, and Nakata index respectively. The cross-sectional area of the different APCs in each patient were summed to yield the total CC of the APCs and proximal and distal points respectively. The cutoff point of the indexed total distal APC CC for the occurrence of composite outcome was identified by ROC curve, and the patients were divided into two groups of high and low APC density determined by calculate distal APC CC cutoff. A total of 41 patients meet the criteria of composite outcome, and the most two common criteria met were hepatic insufficiency and lactic acidosis. There were 3 in-hospital deaths. 2 deaths were cardiac related. The incidence of mortality of was similar between the two groups. However, the occurrence of composite outcome were more common in high APCs density group. Patients with high APC density experienced complicated post-operative recovery requiring greater inotropic support, longer chest tube insertion, longer ICU duration, and overall hospital stay. The MART variable analysis showed high APCs density and non-Nakata indexed as independent predictors for the composite outcome. In TOPIS, APCs are likely to be dilated bronchial arteries. Preoperative MDCT-derived APC density was important as Nakata indexed in predicting the occurrence of in-hospital composite outcome. Patients with significant APCs tend to experience complicated post-operative recovery. The APC CAC of 3.0 millimeter square per meter square may be considered as a threshold for risk stratification. Thank you for your attention.
We have a discussant video for this abstract. The discussant is Dr. Glenn Van Arsdale from UCLA.
Dr. Fang presents an excellent analysis on the physiologic impact of bronchial-type collaterals for repair of simple tetralogy. A lower Nakata and higher distal cross-sectional area of collaterals independently increased adverse physiologic outcome, but not mortality. Increased collateral density was associated with increased inotropic requirement, ventilator, ICU, and hospital days. 41% of patients with high-density collaterals had the composite adverse outcome, double that for the low-density population. Giving some insight, 6 patients with high density went to the cath lab for coiling. All had left atrial pressures greater than 20. Where in the West do we see these kinds of collaterals? In our failing Fontans. Collaterals are a bleeding risk and physiologic stressor. Food for thought as we try to modify Fontan transplant risk. I have 2 questions. Does this data lead you to consider preoperative coiling for a subcategory of patients? And patient size was associated with larger collaterals. Is that also true on an index basis, indicating there's physiologic consequences to waiting? As an aside, many of you work with Children's HeartLink. HeartLink, West China University, and SickKids partnered for many years. The senior author on this manuscript spent more than 2 years in Toronto, where we discovered a talented surgeon and phenomenal academic. My compliments to Children's HeartLink and Dr. Luo for the Hawkins CHSS manuscript.
Dr. Fang, please turn on your camera and unmute your microphone.
Okay.
Now, let's go through some very relevant questions. One from Jim Twaddell is the following. Would you recommend that older patients undergoing tetralogy repair should have a preoperative cardiac catheterization to attempt to mitigate these potential problems? And do you have any evidence, any data that if you do that, then the postoperative course is more benign?
Previous studies show the presence of the enlarged APCs was associated with the prolonged hospital stay and ventilation. However, the current literature has yet to correlate the quantitative amount of APCs with early post-operative outcomes. Given that APCs appear to very common in top, establishing cutoff point of APCs density predicting unfavorable in-hospital outcome is warranted to guideline the clinical practice. Some authors suggest that based on their clinic observation, APC reduction should be performed in patients with an APC diameter to body weight ratio more than 0.5 millimeter per kilogram or diameter more than 2 millimeters. However, the association between this criteria and post-operative outcome has not been validated. Consistent with the previous study, our results confirmed the adverse effect of APCs on the post-operative in-hospital recovery. Furthermore, we proposed a potential cutoff point for the predicting the occurrence of in-hospital composite outcome based on the indexed distal APC-CEC. As shown by our data, the occurrence of major complications such as mortality, circulatory support, cardiac arrest, or renal insufficiency were similar between patients with low and high APC density. Furthermore, no deaths appear to be directly APC related. This result suggests that the large amount of APC's flow could be competent in most of these patients without causing severe complications. On the other hand, one should be vigilant for any sign of post-operative low cardiac output and or respiratory compromise, especially in patients with high APC density. The management of APCs should be early discussed if a complicated post-repair recovery occurs.
Okay, let me ask you a question from a practical point of view. When you have a patient like this on your schedule, do you use this index, this measurement of collateral cross-sectional total area? Do you use this to make a decision as the patient will have preoperative cath to coil the collaterals? And how frequently are you doing that? Is this part of your standard practice now?
No.
You do not use it clinically. Okay. A related question from Jim O'Brien is whether you use this information to change your intraoperative perfusion strategy based on a large collateral area.
Maybe in the future it will work well. Increasing perfusion flow.
A question from Carlos Troconis. Does APC correlate with age and the severity of the clinical presentation?
Yes.
In what way?
Sorry, can you repeat the question?
Do you find that there are subgroups of patients clinically on clinical grounds who have a higher APC or the other way around? Do you find a correlation between high APC and clinical presentation?
Sorry. A total of 337 APCs were detected in 135 patients. The number of right and left APCs was similar. Similar. The majority of APCs site were orthotopic. The most common site of the ectopic APC osteum were at the aortic arch, 55.9%, followed by subclavian arteries. Around 1/3 of APCs originated from the aorta directly. The rest of them arose from the aorta as a common trunk and ICT. All of the 337 APCs caused along the ventral side of esophagus. The proximal diameter of the majority of APCs were smaller than 2 millimeters.
All right, great. Thank you very much. Congratulations for a nice study, and I think we should move to the next presentation.
Thank you very much. The next presentation, Dr. Connor Callahan will now present factors associated with mortality transplant after cavopulmonary shunt for tricuspid atresia versus transition to Fontan. It's a Congenital Heart Surgeon Society analysis. Looking forward to it. Dr. Callahan?
Good morning. My name is Connor Callahan, and currently I'm the Kirkland Ashburn Fellow of the CHSS Data Center, which is based here at the Hospital for Sick Children in Toronto. I'd like to start by thanking the program committee for the opportunity to present our work, as well as to my co-authors for their support in this project and all CHSS Data Center projects. We have no financial disclosures. Of all the lesions that are palliated through the Fontan pathway, tricuspid atresia with normally related great vessels has been thought to be the most ideal. This is due to having a systemic left ventricle, the mitral valve is the atrioventricular valve, and a usually unobstructed systemic outflow tract. Our prior studies identified risk factors primarily related to stage 1 palliation in TA, and at the time were underpowered to identify factors associated with CPS to Fontan interstage attrition. We now have almost 10 years longer follow-up and over 100 more patients since our last study. Since TA is the most optimal physiology for the Fontan pathway, one would expect the rate of death or transplantation to be on the lower end of the spectrum among lesions requiring single ventricle palliation. But as you'll see, this rate is not insignificant. With the prior background in mind, our two objectives are as shown. Number one is to determine factors associated with death or transplantation after cable pulmonary shunt without achieving Fontan completion. And number two is to determine the factors associated with Fontan completion after cable pulmonary shunts. To address the question of optimal Fontan pathway management, the CHSS assembled a TA cohort that has prospectively enrolled newborns with TA with normally related great vessels since 2000. These are the enrollment criteria, and of note, patients must have been less than 3 months of age at the time of their first admission to a CHSS institution. This is a very simple look of how our cohort looks today. While the pathway to time zero of CPS is much more complex than what is shown here, of the 417 patients enrolled as of May 1st of this year, 382 patients have undergone cable pulmonary shunts. Death or transplantation is a combined endpoint, and 17 of these 18 events were deaths, and 1 event was heart transplant. As you'll see, 310 patients have undergone Fontan completion, and the remaining 54 patients are alive without experiencing either endpoint. This chart shows the competing risks after time zero of CPS to 5 years postoperatively. As you'll see, at 5 years, 91% underwent Fontan completion, 5% died or underwent heart transplantation, and the remaining 4% are alive without transitioning to either of these two end states. On the subsequent slides, I'll be showing parametric multivariable hazard analyses for the death or transplantation limb of this competing risk and the Fontan completion limb of this competing risk. Interval surgical and catheter-based procedures were adjusted for time-varying covariates in these subsequent analyses. This is a parametric multivariable hazard model for death or transplantation, again totaling 18 events. A positive estimate means the variable was associated with death or transplantation and is highlighted in yellow, while a negative estimate means the variable was associated with increased freedom from death or transplantation, which is shown in white. Notably, preoperative moderate or worse mitral valve regurgitation, concomitant PA banding at the time of CPS, post-CPS SVC intervention, and CPS takedown were all associated with death and transplantation. Finally, CPS in the more recent era was protective from death or transplantation. This is a parametric multivariable hazard model for Fontan completion, totaling 310 events. Again, positive estimates are associated with Fontan completion, which is shown in white, whereas negative estimates are associated with increased freedom from Fontan completion, which are shown in yellow. Of note, in patients who had an initial BT shunt, concomitant PA banding at the time of that shunt was associated with Fontan completion after CPS. Additionally, the hemifontan CPS type was also associated with Fontan completion. A history of a prenatal diagnosis of TA, a higher preoperative oxygen saturation, concomitant PA banding at CPS, as well as interval procedures were all negatively associated with Fontan completion. In conclusion, patients with moderate or worse mitral valve regurgitation represents a high-risk group. Additionally, postoperative SVC interventions are a poor prognostic indicator. While this study was not designed to investigate the management of competing pulmonary blood flow, the finding of concomitant PA banding being associated with death and transplantation, as well as with decreased Fontan completion, may represent a deleterious effect of leaving competing antegrade pulmonary blood flow in the CPS physiology in TA patients. Further investigation is certainly needed into the management of competing antegrade pulmonary blood flow at all stages of palliation for TA, and we'll be discussing the potential reasons for this in our upcoming manuscripts. I must note that the study was limited by a low number of deaths and transplantation, and it was difficult to determine the treatment intent or strategy in those who are alive without transition to Fontan completion 4 to 5 years after their CPS. Thank you, and I look forward to your discussion and questions.
Thank you, Dr. Callahan. We have a discussant video for this abstract. The discussant is Dr. Richard Jonas from Children's National Medical Center.
I want to thank Dr. Callahan for sending me a copy of his very well-written manuscript that describes a very logical analysis of the now more than 400 patients with tricuspid atresia or normally related great arteries enrolled by CHSS over a 20-year period. This builds on the 2005 report by Karam Liu that looked at the neonatal period and the 2015 report by Wilder that looked solely at the end-of-stage period. Certainly the 95% survival 5 years after the Fontan in this group of low-risk patients is very encouraging, but the 5% loss during the end-of-stage period is deserving of the careful analysis that the authors have given it. The risk factors for not surviving to a Fontan after the cardiopulmonary shunt, like mitral regurgitation, greater need for catheter intervention, and a higher oxygen saturation before the cardiopulmonary shunt are perhaps not surprising. On the other hand, the outcome that leaving antegrade pulmonary blood flow led to failure to get to the Fontan stage, or a higher probability of not getting to the Fontan stage, is difficult for me to interpret and would have been my question for Dr. Callahan. How often was this done electively, deliberately, to increase the end-of-stage period and avoid a Fontan through avoidance of AVM formation? And how often was it mandated by a low oxygen level at the time of the cardiopulmonary shunt, perhaps because of increased pulmonary resistance? Congratulations on a great study, and thank you for the opportunity to comment.
Turn on your camera and unmute your microphone.
Hello, can you hear me okay?
Yes. Dr. Saras?
All right. Here is first, let me start the question by asking you the small subset of patients to which also Richard was referring to, who had both a banding and a shunt. Were these done during the same procedure, or were these done sequentially? First, perhaps a band that became too tight and then a shunt, because it's a little difficult to understand the scenario under which you would have both a band and a shunt for these patients.
Right. And so are you presuming to that finding with the Fontan completion?
Mm-hmm. Yes.
Yeah. So that was focused on a set of patients where they required a shunt sort of in the neonatal period. And for one reason or another, they got a concomitant band. So that band was done at the same time. I don't really have a good explanation for that, but I certainly thought it was an interesting risk factor to include in the analysis to try to get a sense of the competing pulmonary blood flow. Our two previous papers, they sort of came to conflicting conclusions about it. And so the intent certainly wasn't to answer that question in the first stage, but yeah, I don't have a good answer as far as why both were done at the same time in that small set of patients.
Jim Twaddell has a question. Were the patients that underwent banding exposed to increased pulmonary blood flow during the interstage period?
Yeah, presumably yes. I know in some of the app notes I reviewed personally, I think it's there's certainly a range of antegrade flow they were exposed to. For example, there were probably 1 or 2 reports where the surgeon would mention, I tightened the band to, essentially have, quote, minimal antegrade flow, whatever that may mean. So certainly not all PA bands that were done at the time at Glenn were the same, but presumably all of them were exposed to some degree of antegrade flow.
Mm-hmm. I don't see any other questions. I congratulate you for a nice study, and I think we should move on to the next paper.
Great, thank you for the questions.
Nicely done. All right, our next abstract is presented by Dr. Philip Allen from Columbia University and is entitled Down Syndrome Patients Undergoing Cavopulmonary Connections Have Increased Mortality and Morbidity, a Nationwide Multi-Institutional Study. Dr. Allen.
Hi, my name is Philip Allen. I'm a fourth-year medical student at Columbia University, and I'm going to be presenting Down syndrome patients undergoing cavopulmonary connections have increased mortality and morbidity, a nationwide multi-institutional study. I have no disclosures. So in terms of an introduction, trisomy 21 patients have well-established associations with congenital heart defects, including and especially atrioventricular septal defects. Furthermore, functional single ventricle defects, which includes unbalanced AVSDs, typically require stage surgical palliation that includes cavopulmonary connections, that is Glenn and Fontan procedures. And we know that elevated pulmonary vascular resistance, which can and does occur in trisomy 21 patients, results in suboptimal cavopulmonary circulation, which then results in higher morbidity and mortality in patients. So the study aim was to assess in a nationwide multi-institutional cohort of cavopulmonary connection patients the impact of trisomy 21 on patient morbidity, patient mortality, and resource utilization. So in terms of materials and methods, we identified patients undergoing Fontan and Glenn procedures using ICD-9 and ICD-10 codes beginning in 2004 through 2019 in the administrative database PHIS, Pediatric Health Information System. We then stratified them by trisomy 21 status and performed univariate and multivariable analyses, as well as Tobit regression models to analyze accumulating data, because this allows for censoring of data or artificial truncation of data that happens with death of patients. So in terms of preoperative characteristics, I want to point out that trisomy 21 patients were older at time of Glenn and at time of Fontan. They're more likely to be less white than their counterparts. And trisomy 21 patients undergoing Fontan, but not Glenn, were more likely to have perioperative heart failure. We were interested in looking for reasons why trisomy 21 patients might be older, especially at time of Fontan, running if there's a difference in the time between Glenn and Fontan. So we identified patients who underwent Glenn and Fontan at the same hospital, and then did a Kaplan-Meier curve for the difference, and you can see that there's no difference in terms of the overlapping lines between trisomy 21 and non-trisomy 21 patients. There's no significant difference in timing from Glenn to Fontan in these patients. In terms of the postoperative outcomes, you can see that there's a greatly increased mortality in trisomy 21 patients in both Glenn and Fontan procedures. You can see Glenn, 19 versus 3%, and Fontan, 13 versus 1.4% inpatient mortality. And secondly, in terms of other measures of morbidity, including ICU length of stay, total length of stay, and cost, you can see there's greatly increased inpatient costs and increased measures of morbidity for both in trisomy 21 patients for both Glenn and Fontan procedures. And then In terms of other secondary outcomes, postoperative outcomes you're looking at, you can see there's prolonged mechanical ventilation in trisomy 21 patients, as well as prolonged postoperative, increased postoperative infections in these patients. When we looked at the association between trisomy 21 and cable pulmonary connections in these patients, you can see that in terms of both univariate and multivariable odds ratios, there's a greater than 5.5 association for inpatient mortality with trisomy 21. You can see that there's increased associations in terms of length of stay, ICU length of stay on both univariate and multivariable analyses. The only exception to that rule is the ICU length of stay for Fontan is not quite statistically significant. Lastly, you can see there are increased costs and increased variance of costs in terms of trisomy 21 patients in both Glenn and Fontan procedures. And we're also interested in looking at long-term outcomes in these patients. You can see in terms of Kaplan-Meier curve that there's an increased, there's increased inpatient mortality, but then there's increased mortality that continues for this 2-year period. You can see it's significant for this 2-year period, both in terms of Glenn and in terms of Fontan procedures. So you can see that there's a 2-year period where the patients continue to do worse after their procedure compared to their non-trisomy 21 counterparts. So in conclusion, trisomy 21 significantly increases inpatient risk-adjusted morbidity, mortality, and resource utilization following cable pulmonary connections. Trisomy 21 is associated with increased long-term mortality, especially in those 2 years immediately post-operation. And we hope that these multi-institutional data provide benchmark metrics to aid in preoperative assessment and counseling of patients and families. And in line with that, in terms of future directions, I think it's very important to identify risk factors for trisomy 21 patients using a clinical database. Fortunately, administrative databases don't have that enough granularity for that. And hand in hand with that is a clinical discussion of preoperative care for these patients that might be answered using a clinical database. And perhaps there are measures to treat this, such as maybe instead of doing univentricular repairs after the first stage of palliation, doing a biventricular repair, prophylactic tonsillectomy, adenoidectomy, but these are questions that may be better answered with a clinical database. And lastly, to integrate genetic and syndromic data into risk classifications, such as the STS scores. Here's a list of references. I think we'll open up the floor to questions. Thank you.
Thank you, Dr. Allen. Very nicely presented. We have a discussant video for this abstract. The discussant is Dr. Chaki El-Zain from Advocate Children's Hospital in Chicago.
Congratulations, Dr. Allen, on your work and an excellent presentation, and thank you for sending me the manuscript ahead of time. I want to thank the organizing committee for the opportunity to discuss the paper. Dr. Allen and colleagues reviewed the pediatric health information system for patients with trisomy 21 who underwent cavopulmonary connection performed at over 50 US hospitals over a 15 years period. The prevalence of Glenn and Fontan were 1.5 and 0.8% respectively. Trisomy 21 patients have significantly increased unadjusted mortality, increased hospital length of stay and total hospitalization cost, and higher incidence of prolonged mechanical ventilation after both the Glenn and the Fontan. On multivariable regression analysis, trisomy 21 patient had 5.5-fold increase in mortality, with also higher long-term mortality compared to their peers, especially in the first 2 years after cavopulmonary collection. The study has the inherent limitation of being retrospective in nature, and the fact that it is multi-center makes it prone to inability to identify confounding variables that may affect the results, and identification of these patients based on administrative codes may have also missed some patients as well. In 2017, we reported our series of trisomy 21 patients who underwent the Fontan procedure over a 13 years period ending in 2012. The prevalence of trisomy 21 in our series was around 9%. A fenestration was used in 78% of the patients. Out of 10 patients who had their Fontan done, there was 1 takedown and 1 late death. There was need for longer mechanical ventilation and longer length of stay. The results showed that the presence of native pulmonary artery banding and doing a fenestration were protective for a longer survival. We were aggressive as well with anticoagulation and pulmonary vasodilators at home. all patients were started on heparin immediately after surgery, and they were discharged home on Coumadin, aspirin, as well as pulmonary vasodilators. So I have a few questions for Dr. Allen. In your series, the prevalence of trisomy 21 was a little bit lower than our series, and it was higher in the Glenn patient, 1.5%, than in the Fontaine patient, 0.8%. Do you know whether these are Glenn patients who are not candidate for Fontaine, or they did not reach the Fontaine age yet? Do we know if there were trisomy 21 patients who were not candidate for Glenn? Do we know what anticoagulation these patients received? And is there a way we can look up the database for the underlying heart lesion and previous palliation that these patients had to try to dig into the reason why trisomy 21 patients had higher mortality? We know hypoventilation and elevated PVR is one of them. Again, congratulations for your work and an excellent presentation.
Thank you. I may have missed the beginning of the question, but to address the administrative database side and the use of sort of preoperative characteristics and identifying more information about these patients, one of the problems or one of the benefits of using administrative data is that it's fairly codified and fairly concrete in the sense that these patients, we know that patients have trisomy 21. It's fairly straightforward in that sense. But in terms of looking at the previous surgeries, it's dependent on whether these surgeries happen at the same hospital, because it's all administrative based. And with that, we also lose some of the kind of granularity that comes with the clinical database. So that's why I think in some of the future directions I was talking about, why we need a clinical database analysis, because we don't have information like things like cardiopulmonary bypass time, what sort of anticoagulation these patients were on. This is, in a way, using an administrative database is kind of looking at it from the 30,000 to 20,000 foot view. So unfortunately, we don't have that information, but I think it'd be very important moving forward to look at things like that.
Well, that was, I think, a good answer to a complex question, because the data is not there in an administrative database. I would like to relay to you the question asked by several of our members regarding PA pressures, and I guess that you don't have that information. A surrogate variable, as raised by Dr. Anagnostopoulos, could be number of interstage catheterizations as a surrogate for suboptimal hemodynamics and the need to wait. Do you have any information along these lines?
No, we don't. That's very interesting. A little bit hard to sort of get that, because this is, again, administrative data. It would have to be, you have to be looking at catheterizations that happen specifically at that hospital. And that's not something we looked at. We didn't really spend a lot of time looking at the, I guess, pre-procedural hospital visits. Partially because that tends to get very complicated when you start looking at through administrative data and the procedure codes for that. And secondly, it wasn't necessarily the aim of our study. But one thing we did do in terms of secondary analyses was we looked at stratifying these patients by pulmonary hypertension, because that is one of the diagnostic codes. But we saw similar rates for patients, looking specifically at the trisomy 21 patients, those with pulmonary hypertension kind of encoded as a diagnostic factor. So that didn't affect the outcomes either.
All right. There are many questions from the audience. This is a great study, but I think we must move on to the next presentation. I congratulate you. Thank you.
Thank you.
Thank you, Dr. Saras. Our next abstract is entitled Survival and Reintervention Following Elective versus Rescue Coronary Osteoplasty for Congenital Heart Disease. This multi-center study is being presented by Junko Kobayashi from the Hospital for Sick Children, Toronto. Dr. Kobayashi.
Thank you very much for the great opportunity to show our data in this session. I have nothing to disclose. Obstruction of coronary ostium in children is rare, but life-threatening, and it is mainly caused by congenital coronary malformation and complication of congenital heart surgery. Coronary osteoplasty is the only viable reconstruction method in smaller children to restore antegrade coronary flow. However, it is technically challenging, and survival is influenced by multiple factors. The purpose of the study is 1. To analyze survival and reintervention rates and identify predictors for poor outcomes in children. 2. To analyze the outcomes with special interest on the mode of the intervention, which is elective versus rescue osteoplasty. We defined rescue osteoplasty as a coronary osteoplasty as the urgent surgery for hemodynamic instability or the salvage procedure for the complication of coronary artery during the congenital heart surgery. The methods are shown in this slide. We reviewed all of the open heart surgery at the Hospital for Sick Children between January 2000 and March 2019, and 63 patients who underwent coronary osteoplasty were identified. Patient characteristics and the outcomes were analyzed. Predictors for the mortality and coronary reintervention were analyzed. Regarding the methods for the statistics, freedom from death were analyzed using Kaplan-Meier analysis and the log rank test. The cumulative incidence rate of reintervention were analyzed using competing risk models. Risk factor analysis was done with univariable analysis. Then significant variables were included in multivariable analysis. Patient characteristics are shown here. The median age was 241 days, and median body weight was 10.2 kg. Preoperative ECMO was needed in 14.3% of the patients. As a diagnosis, 36.5% had TGA, 19% had AAOCA, and 25.4% had supra-aortic stenosis. Regarding the coronary lesion, 73% of the cases underwent osteoplasty in left coronary artery and 14.3% in both coronary arteries. As the osteoplasty technique, 69.8% had patch osteoplasty, 23.8% had unroofing, and 60.3% had ridge resection. 33% had the coronary reimplantation as a concomitant procedure. Perioperative outcomes are shown here. Postoperative ECMO was needed in 27%, and delayed chest closure was done in 41.2%. Freedom from death is shown here. Overall freedom from death in 10 years was 81.6%. Interestingly, elective osteoplasty cases had no mortality. On the contrary, the freedom from death in rescue osteoplasty cases was 49.6%, which was significantly lower than elective cases. And all of the deaths happened within 1 year after osteoplasty. Factors associated with the mortality were shown here. Preoperative ECMO and longer cardiopulmonary bypass time were shown as risk factors in the multivariable analysis. The proportion with the coronary reintervention in the entire cohort was 21.3% in 10 years. The proportion was 14.1% in elective cases and 33.3% in the rescue cases, respectively. The proportion in the rescue cases was significantly higher than elective cases. As the factors associated with coronary reintervention, invariable analysis showed preoperative ECMO and rescue osteoplasty were statistically significant. However, there was no difference in multivariable analysis. Lastly, We focused on coronary event to osteoplasty time in the rescue group, which reflects the degree of myocardial ischemia. There was no statistical difference of the time between survivors and non-survivors, and between survivors with or without coronary reintervention. In summary, elective osteoplasty provided excellent survival with an acceptable reintervention rate. The need for rescue osteoplasty is associated with low survival and high reintervention rates. This may be related to the limited time for decision-making and/or difficult probability recognition of coronary stenosis in this population, resulting in irreversible myocardial ischemia. Event-to-surgery time in the rescue group did not affect the mortality and coronary reintervention. In conclusion, although some rescue procedures are unavoidable, well-planned and potential elective intervention may yield a better survival and lower coronary reintervention. Thank you for your attention.
Great. Thank you. Dr. Kobayashi, please turn on your microphone and on your camera, and unmute your microphone. I think, George, we can open up the floor to questions. Just one quick question. I know at the Hospital for Sick Children, the capacity to do intraoperative assessment of coronary anatomy is quite well developed. Was there any correlation to the efficacy of establishing coronary flow in the operating room with long-term outcomes? Dr. Kobayashi, you need to unmute your microphone. Dr. Kobayashi, are you able to hear us? You need to unmute your microphone, please.
Can you hear me now?
Yes, we can. Thank you.
Thank you. So thank you for your question. So actually, we haven't checked the coronary flow in OR yet. Yes, I can hear you, but I don't know.
Sounds like there might be some echo.
Can you hear us?
You're muted again, it appears. Your microphone appears to be muted. Well, maybe we'll be able to circle back for some of the questions. It seems like we have a technical problem with the sound.
Mm-hmm.
Are you able to hear me now? No.
Can you hear
Okay.
us? No.
I think we'll just move on because clearly you're having a technical problem, and maybe at some later part of the program we'll be able to respond to your questions, perhaps through the chat link. Okay, thank you very much.
Yes, I can hear you, but I'm a lot of echoing. So.
Okay, well, thank you very much.
Sure. Thanks.
Next, Dr. David Morales will present a novel bioabsorbable pulmonary valve conduit early feasibility study and first-in-man early results. Dr. Morales.
I want to thank the Society for allowing us to share some early results on a novel bioabsorbable pulmonary valve conduit. These are our disclosures. The technology behind this novel RV to PA conduit is called RestoreX. It is based on some work by Nobel Prize winner Professor Len. This technology is based on tunable supramolecule polymers, which mean they can be changed quickly to display different characteristics. Electrospinning allows the polymer to form into particular microfibrous architectures, and shapes consistent with a blood vessel or a valve. After implantation, it is felt that the polymers will attract cells to populate the material and eventually replace it to form durable, viable valves and vessels. This technology is called ETR, or endogenous tissue regeneration, and has shown promising results in animal studies. Currently, there is no perfect RVDPA conduit, and when implanting these conduits in neonates, we realize there will be a lifetime of surgeries and interventions ahead of them. The current devices, as you can see here, have poor performance due to stenosis and calcification, as we know, requiring exchange. This conduit's wall consists of one polymer, while the leaflets are made of the same polymer tuned slightly different. The leaflet material is more flexible and degrades more slowly than the conduit material to accommodate the needs of the moving leaflet and a longer time in which to be populated with cells. The Explore-1 trial was a non-US trial consisting of 12 patients. This also included the first-in-man use. As you can see, this was used in Hungary, Poland, and Malaysia. The average age of patients was approximately 7 years old. It was used, the conduits used were 16 and 18 millimeter conduits and were used in different types of environments, including native RVOTs as well as for conduit exchange. As you can see here, there were no reoperations over the 3 years, but there was significant insufficiency of the conduit. 75% of the cohort had significant insufficiency by 3 years, and over 50% by a year. The diameters of the conduits remained stable. There was no calcification and no dilatation. As you can see here, there was a slight increase in stenosis, but still very mild stenosis at 3 years. What we learned from Explore-1 is that we had to do something about the insufficiency. So this technology has the advantage that these polymers are tunable, which means that they can be manipulated to change their characteristics or their properties. Because of the insufficiency, the leaflet's polymer was changed or tuned to be thicker and more durable with a slower degradation process, but remained flexible for movement. Once this was done, we tried the Explore-2 trial started, which was a US exploratory trial of only 6 patients in 4 centers. In this trial, only the 18 millimeter conduit was used, and it was used mostly as a conduit exchange, but in a Ross in 2 patients. Here, we did see one explant or exchange of the conduit at 12 months. This was in a patient who was known to have an inflammatory process, an autoimmune process. The patient also had tubular sclerosis and has had difficulty with different conduits. Having said that, what was most important is that there was no significant insufficiency at 12 months. And again, in the Explore-1, there had been over 50% at 12 months. Again, there was a stable diameter, no calcifications, and no dilatation. And unlike the Explore-1, we did not see any signs of stenosis at a year. So in summary, this is the first ever clinical trial with this technology, this restorative pulmonary valve conduit, and it was done in 18 patients, which I think shows more than enough for clinical proof of concept. There were good procedural and clinical outcomes. It was quite promising that there was very little re-intervention or reoperation. The conduit diameter was quite stable, perhaps showing signs of healing since at 3 years it remained stable. However, this will require further study. Most important, the company was able to tune these polymers in order to address problems with performance. Between the Explore-1 and the Explore-2, they changed the polymers so that we could get rid of the insufficiency. I think the ability for the company to efficiently change the performance or the polymers in response to what we see clinically makes this very unique technology. These outcomes have resulted in the FDA approval of a combined EXPLORE2 pivotal trial, which will include 50 patients and is starting in the summer of 2020. These are the 10 investigators or areas or hospitals that are involved in this. Thank you very much.
Thank you. Dr. Morales, could you please turn on your camera and unmute your microphone, as I can see you have. Dr. Saras?
David, congratulations for a nice study, the nice presentation. We hope this will work, of course. We need a conduit. The data is encouraging, but out to about a year now only. So a lot remains to be seen. There are many questions from the audience. One from Peter Gruber is, do you have evidence about what kinds of cells populate this conduit and the valve leaflets from explant data? Do you probably do have explant data from animal studies, I imagine.
Yeah, so I want to be clear that I am representing a lot of different people who've been involved with this technology for a while. I was not involved in the animal studies, but there are several animal studies demonstrating that in fact the appropriate cells are going back into the conduit and repopulating it. In terms of human studies, we do not have any of that. There's only been one explanted conduit, and actually that was my patient, and it's a patient who had tubular sclerosis and has had difficulties, has kind of an autoimmune / inflammatory process that continues to happen, which is what happened to his aortic valve originally, and then he got a Ross, and he's gone through a few conduits, all of which he continues to fibrose very quickly. So that conduit obviously did not show anything promising, but there are no other human conduits that have been taken out.
Jim Yeager was asking, what was the mode of failure in the initial study? Was it leaflet disruption, shortening, shrinking, fibrosis? And a related question is, what was modified in the second version to try to mitigate this?
Yeah, it was shortening, and what was modified, again, these are super molecules, some type of polycarbon. So to know exactly what the molecule, how they changed it, I don't know. But what they were able to do, what they wanted to do, was make the leaflets that, again, the conduit wall is different than the leaflet. They're the same family of polycarbons, but they're changed a little. And so what they did is they somehow added something to it to make it last longer, so it wouldn't shorten, remain pliable, and a little more durable. That's what they're saying. The exact molecules they added, I would have no idea.
David, another question from a couple of members. Do you have any information on whether anticoagulation, antiplatelet or conventional anticoagulants are used or recommended with this technology?
We haven't. I put my patient on aspirin, but the patients do not require anticoagulation with this conduit.
But you do use antiplatelet agents routinely?
Not routinely. Again, we've only, in the US, we only put in 6, so there's nothing routine about it. The company is not requiring any anticoagulation. And as far as I know, in Europe and in Asia, they did not use it. Again, these are very preliminary results and exploratory. I thought it was worth sharing. What struck me about the technology is how quickly they can respond to a decrease in performance. Saying, okay, the leaflets aren't, working well, and then within a 6-month period, they can turn around, produce a new conduit in which they think the leaflets will work better. And they were able to produce that, at least in these conduits that we saw for a year. I thought that was very, unique, and which is why I wanted to become involved with exploring more about the conduit.
David, I realize the number of patients implanted is small, but nonetheless, do you have, and Elizabeth Stevens is asking this, is there any data on whether the degradation varies with age?
We don't have that data. I don't think we could state that. All these patients are about the same age, so I couldn't say that.
Thank you very much, David. Nice presentation, and I hope this works going forward.
Yeah, well, hopefully I'll present the 50 patients in years to come, in about a couple of years. Thank you.
Chris.
All right, our final abstract of session 2 is being presented by Dr. Kalfa, entitled Tricuspid Valve Surgery for Non-Epstein Congenital Diseases, Indications, Outcomes, and Prognostic Factors in the Modern Era. Dr. Kalfa.
Thank you to the CHSS and the ECHSA for the opportunity of presenting this paper. I'm Dr. David Kalfa from Columbia University, New York. We'll talk about the tricuspid valve surgery for non-Epstein congenital disease. I have no disclosure. There is little data about the surgical indications, outcomes, and prognostic factors of the specific population for non-Epstein congenital tricuspid valve lesion. It's a very heterogeneous population with different etiologies and different outcomes. We included all the patients who had tricuspid valve surgery for non-Epstein congenital tricuspid valve disease between 2006 and 2018. We excluded patients who had an AV canal defect. The primary endpoint was tricuspid valve reintervention or regurgitation, moderate or more than moderate, and the secondary endpoint was cardiac-related death. 113 patients were included. Most of them had a tricuspid valve regurgitation. Tricuspid valve lesions was related to an RV, RVOT, or PA obstruction in 1/3 of the patient. Overcirculation related to a left to right shunt in a quarter of a patient, single ventricle associated lesions in 15 patients, systemic tricuspid valve in 9 patients, a iatrogenic lesion of the tricuspid valve in 9 patients, and a congenital tricuspid valve lesion in 9 patients. The patient who had a repair were significantly younger. Patient who had a replacement had significantly more systemic tricuspid valve in terms of etiology. Patients who were younger had significantly more single ventricle lesions. 3/4 of the patient had a repair, mainly with an annuloplasty or commissuroplasty. Was a significant amount of concomitant surgery or procedure, and 1 patient needed ECMO in the OR. 4 patients required an ECMO, and 3 patients died during the same admission. All of these patients were single ventricle patients. At a median follow-up of 3.3 years, 30% of patients had a recurrent tricuspid valve regurg, moderate or more than moderate, 12% a reintervention of the tricuspid valve, and 5 patients died. This diagram summarizes the outcome by the underlying physiology, single ventricle, systemic tricuspid valve, and all the other patients. The vast majority of the patients had a repair, except in the systemic tricuspid valve group, who had a replacement mainly. Overall, the outcomes are pretty good, except in the single ventricle population, as expected. Patients who had a systemic tricuspid valve and had a repair instead of having a replacement had a significant amount of tricuspid valve intervention or residual regurgitation. Patients who had repair had a tendency to have more recurrent tricuspid valve regurg down the road, but just a tendency. Patients who were younger had an increased risk of ECMO, death in hospital, and recurrent tricuspid valve insufficiency or reintervention. Regarding the composite endpoint of tricuspid valve reintervention or tricuspid valve more than moderate, you can see that this was associated with a younger age at surgery and a single ventricle patient. The univariate analysis confirmed these findings. with a younger age, the single ventricle patients, and also an MR more than moderate. And this was confirmed in the multivariate analysis. Overall, the actuarial risk of tricuspid valve intervention or recurrent regurgitation was around 20% at 5 years. With, again, that was more frequently the case in single ventricle patients and younger patients. In terms of cardiac-related death, the main factor significantly associated with this risk was the single ventricle patients, as confirmed by the univariate analysis. Overall, the actuarial risk of cardiac-related death was pretty low and stable, with a significant higher risk in single ventricle patients. To conclude, tricuspid valve surgery in non-Epstein congenital patients yields good outcomes. Single ventricle associated tricuspid valve disease is an independent risk factor for tricuspid valve reintervention or regurg moderate or more than moderate. Single ventricle associated tricuspid valve disease and younger age at surgery are associated with a significantly higher risk of reintervention, regurgitation, or death. The tricuspid valve replacement itself is not a risk factor for death, and the tricuspid valve repair was not a statistically significant, risk factor for residual or recurrent tricuspid valve pathology. Thank you very much for your attention, and I'm happy to answer any question.
Thank you, Dr. Calfa. We have a discussant video for this abstract. The discussant is Dr. Christian Pizarro from Nemours Children's Hospital.
Christian Pizarro, cardiothoracic surgeon at Nemours Cardiac Center, Aphrodite Dupont Hospital Children, discussing characteristics or outcomes of patient undergoing surgical repair non-Epstein's congenital tricuspid valve disease by Dr. Calfa, Blitzer, and colleagues from Columbia University. I'd like to congratulate the authors on an excellent presentation and a very challenging group of patients. This cohort includes a very diverse anatomic substrate and a broad age range with almost two distinct patient populations. The overall outcomes were very good, with the cardiac-related death were less than 5%, and younger patients had a higher incidence of ECMO and mortality prior to discharge, as well as tricuspid regurgitation greater than moderate during the follow-up, and a higher incidence of tricuspid valve reinterventions at 5 years, as well as cardiac-related death. Particularly concerning is the fact that patients with single ventricle had a 15% mortality at 5 years. Based on this data, it seems that significant right ventricular dysfunction greater than moderate was present in about 25% of these patients. How do you think that the presence of right ventricular dysfunction influenced the durability of the repair itself, for example, the use of an annuloplasty, and the decision to replace the valve? Similarly, although annular dilatation is a common mechanism for central tricuspid regurgitation, only 44% of patients receive an annuloplasty. What was the criteria to perform this type of intervention, and how could this influence the durability of the repair itself? Analysis of predictors of tricuspid valve reinterventions included age, weight, mitral regurgitation, and single ventricle physiology. Although the overall cumulative incidence of reintervention at 5 years was 21%, this reached 34% in the younger patient group and 37% in single ventricles. Do you think that these patients could have benefited from an early intervention, or should the valve just be replaced? Dr. Calfa and Blitzer have stated important facts and a number of important questions. It is apparent that this analysis could facilitate our understanding of this complex yet understudied issue. Congratulations on an excellent presentation.
Dr. Calfa, could you unmute your microphone and turn on your camera? Thank you.
So to answer to the question of Dr. Pizarro, the first question was about the RV dysfunction. So overall, and he was also asking about the indication. So overall, we favor the tricuspid valve repair over the tricuspid valve replacement, except for the population of CCTGA, congenitally corrected TGA, a patient who have a systemic tricuspid valve, because we know from previous data from the literature and from the data that this patient with systemic tricuspid valve but who have a repair actually need either a repair or a replacement down the road. So, but this population put apart, our strategy is really to favor the repair. What is the impact of an RV dysfunction on our indication for a repair? It doesn't have actually an impact. It's not because a patient has a significant RV dysfunction that we would lean towards a replacement. So that is to answer to the first question. The second question was about the single ventricle population who has significant TR. So in this population, should we move forward and treat more aggressively this patient with having an early lower threshold to intervene? Yes, probably. The timing of the tricuspid valve repair in this single ventricle population, it varies between, the vast majority of them were operated at the time of the Glenn or after the Glenn.
Okay. David, this is a very nice study. In fact, you managed to put together 3 reports into one, because these are 3 different, very different patient populations. And I think discussion would be facilitated by perhaps in the interest of time, just focusing on perhaps one of these populations. In the biventricular patients, there are many questions from the audience. Have you included patients with tetralogy of Fallot who come back, let's say, for pulmonary valve replacement, and they have TR based on RV dilatation? And what has been approach for this?
Yes, absolutely. So you're completely right, George. We really put together these different populations because we wanted to have a an overall picture of what's going on with this tricuspid valve in the congenital population. But these systemic tricuspid valve, single ventricle, and biventricle group with the valve in the right position are different. So to answer your question, yes, we included the patients who had Fallot and a tricuspid valve regurgitation. And actually, so we clustered and put together this patient in the group of tricuspid valve regurg related to any obstruction on the RVOT tract, right? So in the RV or in the RVOT, or have a pulmonary atresia or pulmonary stenosis. So the patient that you're talking about are put in this group. So in this group, the tricuspid valve regurg is mainly related to 2 things. Number 1, as you said, the tricuspid annular dilation, and number 2, also the fact that the septal leaflet of the tricuspid valve can be stuck on the VSD patch. So what we usually do in this patient is again repair. We almost never replace these valves. This repair can be challenging actually technically, because sometimes it can be quite difficult to delaminate, if I can say that, the septal leaflet from the VSD patch. But this is something which can be done, and then we can also augment this septal leaflet using a patch if needed, in addition to the annuloplasty or any type of commissuroplasty.
Luca Brisella was asking if in the repair cohort you stratified the rate of recurrence by technique, ring, no ring, and so forth.
Yes, we did, and no difference, Luca. We looked into it. And we actually looked into it specifically in the group of single ventricle patients because they are very challenging. And there was no basically difference in terms of outcome if we stratified by the type of repair that we used to do.
So as Hani Najm asked, is there a type of repair that's faring better than others?
Not really. We were not able to identify that. It's really, it's not a one technique fit all, I would say, but it's really case by case. And as usual in the world of valve repairs, it's really based on the assessment of each specific valve that we have to offer to each patient the adequate type of repair.
And a question from Glenn Van Artsel. Do you have specific data on biologic tricuspid valve replacement under 10 years of age?
Yes, so less than 1/3 of our patients got a replacement. Among them, two-thirds among them had a biological replacement. 1/3 was mechanical valve replacement. Among the biological tricuspid valve replacement, we usually use and we prefer to use porcine valve instead of pericardial valve, and this has been shown in the literature that the pericardial valve in this very low pressure environment tend to degenerate faster. And so our data, and we didn't show that here, but our data confirm that the porcine biological valve give better outcomes compared to pericardial bioprosthesis in the tricuspid position.
And one last question, David. In single ventricle patients, this is from Oktay Korun. In single ventricle patients, at what stage was the tricuspid valve repair performed? Was it before or concomitant with the Glenn, or at what stage was it done?
Yeah. So the two most frequent stages in terms of timing was number one between stage 2 and stage 3, and number 2 at the time of the Glenn, at the time of the stage 2.
All right. Thank you very much. Congratulations, David. Nice presentation.
Thank you very much.
Chris.
Thank you all for a very nice session. I think we'll move on.
Well, thanks everyone for your participation in our first 2 scientific sessions. It's really great to see such engagement from the audience with the Q&A function. We currently have 321 registrants and over 150 people on this line. So, I mean, it's pretty impressive what technology can do. And by the way, this is the first, meeting where we're actually on time, if not even a little early. So we will now hear from Dr. Joseph Durrani as he delivers his presidential address. First, I would like to invite Dr. Jim Tweddle to provide a more formal introduction.